meantime, they have some concerns regarding the digital implant dentistry. So the fear of, from the new technology may make a barrier for them to use this tool and to apply it in their practice. Mainly today, I will talk about generally about the digital implant dentistry, and but also then I will present some clinical cases in the end of this talk. I will start my presentation with a quote. Many of you that attended my lectures before, I like to write some quotes, and this quote today is, "Dentistry is a science, and every dentist should know its basics." What I mean by basics is that knowing fundamentals in prosthodontics regarding occlusion, phonetics, aesthetics, classical literature, the textbooks, and to know how to diagnose the case, doing the treatment planning, and then execute the treatment properly is the best way to assure a very good outcome. So without knowing the basics, actually we cannot apply or practice any kind of dentistry properly, including the digital dentistry. I will compare conventional dentistry, as you see here in the slide, with driving an old car or driving a conventional car. So driving conventional car, by knowing the basics, I will say again, of driving, how to use the main things in the car, like the manual gear, or how to drive safely, knowing all the instructions, is the key way to later on to know how to drive the most recent and advanced cars. So this is what I want to say. In digital dentistry it's a tool, a new advancement in the field of prosthodontics or in dentistry. So modern dentistry is really based on the conventional dentistry. And this is what I want to stress today. Just going and attending some new courses regarding how to use some new machines without knowing the conventional way of the practice, this might lead to errors or problems of applying this new technology. So as I say and mentioned earlier, my presentation here will start step by step the basic knowledge for I know there is a lot of audience, maybe general practitioner. I will go step by step for implant treatment, and then I will say in detail the digital dentistry. So as we see here in this slide, we see the edentulous patient came to us here, and partially edentulous patient, and then he wants to restore this space with an implant. Usually, what we should do is a proper diagnosis, and followed by seeing the radiograph, checking the amount, the width of the bone, the patient health and everything, and then plan the placement of the implant correctly And as many previous doctors here through the webinar showed us how it is a prosthetically driven procedure. So knowing where is our final teeth or crowns will be dictate the correct placement of the implant. So usually the periodontist or a surgeon or even a prosthodontist can place an implant here, 2 implants, and nowadays they place cover what we call it a healing abutment. These healing abutments allow the gingiva to heal nicely. As we see, it's very smooth around this healing abutment. After that, we wait 3 months minimum for osseointegration, or it's depend on the case, but we wait for the osseointegration to happen. Once this is completed, now it comes our turn. Conventionally, we use something is called impression coping. As you see here, it's a post that we attach it to the implant, and its main job is to transfer the implant position from the patient mouth to the cast. So we inject the impression material, we take the impression, and then we need another part we call a lab analog. It's a replica for the implant. It's not an implant, but it's something looks like an implant, have the same diameter of the implant and the internal connection of the implant. We attach it to the impression coping, and then we insert it back into the impression as you see here in the picture, and then we pour the cast, and now we have transferred the implant position exactly from the patient mouth to the cast. This is the conventional way. Next to that, after that, we fabricate any superstructure for the implant. Here, for example, we use something called abutment. Abutment, it's the similar word for natural tooth abutment, which is the prepared structure that received a crown. In this case, here we place here 2 abutments, and this could be a stock abutment, which means prefabricated from the same implant company. You can select the proper size and shape for the stock abutment and use it, or you can do something else. We call it customized abutment. I will show it to you in the next few slides. So here, after that, you can fabricate conventional crowns and just cement it on top of the abutments. I'm trying to be as simple as possible, take the thing step by step to know the conventional way, the basics, and then we will move forward. So our purpose here for impression taking is to transfer the size of the implant, the depth of the implant, and the position and angulation, and the soft tissue contour around the implant itself, exactly from the patient mouth to the cast. And here, what it looks like. As you can see in this picture, we have on the left side the clinical picture of the real case, and the right side is the picture of the definitive cast. And we can see the position of the lab analog is very similar to the implant in the patient mouth regarding the depth. As I said, the position, I mean the location, the width, I mean the diameter, the size of the implant itself, the same internal connection, and also the soft tissue around the implant, it's the same. So now we can fabricate the crown on top of this lab analog. So the type of crowns on top of the implant, it could be cement retained, and I explained to you the parts. Here we can see the implant. Then it comes the abutment. As I explained earlier, we attach the abutment to the implant using a screw, the black one, as we see here. And then we cement the crown. As you see in the fourth picture here, it's a cross section after the cementation. So it's we can see the abutment is fitted to the implant internal connection using the screw. Then we just protect the screw head with any medium, such as Teflon tape or gutta percha, or like here in the picture, cotton. And then we apply the cement and cement the crown. The other type is a screw retained implant crown, which is the crown itself and the abutment is one unit. And there is a channel through the crown and access hole that allow us to insert the screw through it to attach the crown to the implant. As you see here in the pictures, a cross section shows that there is an access channel through the abutment and the crown, and which they are one unit, we cannot separate them. And then also we protect the screw head by any material, and then we close the access hole with a restoration, and this is what we call a screw retain. In the end, both crowns look the same, but different techniques. Here, this is, as I showed you in the animation before, this is a real case. I thank Dr. Abdullah bin Mahfouz to share with me this slide. In the upper left corner, there is an impression coping attached to the implant before taking the impression. The upper two pictures, we can see clearly now the impression coping attached, secured to the implant. And then we just take regular impression. After we take the impression, we attach the lab analog in the middle here. If you see the purple lab analog, we attach it to the impression coping. We insert it back into the impression and pour the cast. And this is how the cast looks like in the lower right corner side. So all these procedures are the conventional procedure during making implant prostheses. For instance, here, this is a prefabricated abutment. After we took the impression and we see the implant is in a correct position and there is no severe angulation that require us to do a customized abutment, we can use a prefabricated abutment or a stock abutment from the implant company itself. It comes into different material, different angulation, different shapes, different sizes. We select the proper one, and we can evaluate it in the cast and in the patient mouth, and then we can fabricate a crown and cement it on top of it. On the other hand, this is the most preferable way to me, is to do a customized abutment. There is something called UCLA abutment. You can see it in the upper left picture here, inserted into the implant in the cast. We can notice here that the implant angulation, we cannot say it is wrong angulation, but usually the surgeon must follow the bone, and sometimes after extraction, it's followed by certain resorption, and then we are forced to place the implant in different angulation than the neighboring tooth. So here we can see clearly that the abutment are sticking out, and we should modify its shape to receive a good contoured crown. The putty here show the dimension of our future crown that guide us to waxing up these abutment. So this abutment always comes into like a plastic cylinder that attached to a gold collar down that fits to the implant hex. This plastic, we can, first of all, grind from it or finish, remove from it to reduce the angulation, and then we can wax it up to the proper shape we like. The proper shape we like, using this guide, what makes us call this abutment is a custom abutment. We are customizing the shape of the abutment to this specific tooth. It means that we locate our finish line, as you see in the cast here, properly following the gingival contour and slightly subgingival. So our margin doesn't show during smile. Also, we should design our abutment so it is not very thin or very small, and then we have a large crown that fails due to lack of resistance and retention force. So we design this abutment. This is what I mean by knowing the basic knowledge and the basic principles. Designing this abutment, customizing this abutment according to the resistance form, retention form, location of the finish line, to support the superstructure. Then we can cast this wax into any metal we like the lower right picture. For here, this is a case that the implant patient is missing almost half of his teeth from the lateral incisor to the premolar or molar area. And there is a 3 implant distributed here. So the proper way is to really do a waxing up of the future crowns or bridge fixed dental prostheses before we continue restoring this case or fabricating or selecting the abutments. So the conventional way is we should do waxing up, okay, and then we create our silicone index to see where is the teeth. Of course, this waxing up, we should try it in the patient mouth, whether to convert it to conventional or removable partial denture. I mean conventional provisional restoration, so we can evaluate the aesthetic, phonetics, and then if everything is satisfied, we should follow what we gained by this waxing up to create our final prosthesis. We can see here the relation of the teeth to the implant position. Some of the implant now is in the perfect position, but we can see the middle one, it comes in the middle of the embrasure between the 2 premolars. So here in this picture, we can customize our abutment to follow the future final prosthesis correctly and to give the maximum support and aesthetic to the final prosthesis. Meanwhile, we can also, for instance, if we are doing PFM restoration like here, we can also use this index to allow us to do the metal framework with a good design. So we can see here all the metal are following the anatomy of the wax we are already created. And later on, if we apply the porcelain on top of it, it will be having a good support with even thickness. So we elongate the longevity of these prostheses and minimize any future prosthetic complication. Here, the abutments tried in the patient mouth, and then this is the final prosthesis, and we can see now the embrasures are open between all the teeth, and it look nice also in the patient mouth. So this is the traditional method. Traditional methods I always insist to put this slide so the names of all these prosthetic components of the implant stick to our minds, because if we know the component and its function, then we really can restore any kind of implant, any type, type of implant, because some companies have different names or different they call the parts differently, like the impression coping. Some people, they name it impression post, the lab analog. Sometimes they say implant replica. Regardless of the name, if we know the function, then we can, if we open the catalog for every company, then we really can find the prosthetic component that we look for and select the proper one for our case. So for the traditional method, usually we use a healing abutment to allow a soft tissue healing. Then after that, after osseointegration, we try to use the impression coping to transfer the position, to take the impression and to transfer the position from the cast to the patient mouth. Then we need the lab analog to replicate the implant in the cast. And finally, we need to buy either a stock or custom abutment. But in digital implant dentistry, some of the techniques, we can avoid these three items, and just using a healing abutment called a CAD/CAM healing abutment. That is, as we see here in the picture, it has some engravings on top of it, a blueprint, like certain codes that can be read by a scanner and software, and then the software can determine the width, the size of the implant, the angulation of the implant, the location of the implant, without the need of taking a regular impression. If we can see the codes here, I mark it with stars. So basically the surgeon, instead of using a conventional healing abutment, after surgery, he can just place this one. It's just supposed to be located, the surface of these codes, not covered with the gingiva. So at least 1 millimeter above the highest gingival crest around the implant. And if he used this, then there is no need for using impression coping, etc. One of the advantages of this one, of using a CAD/CAM abutment, a healing abutment, is reducing the necessity of just unscrewing many times the healing abutment. And some literature and indicates that these reduce the micro movement around the implant is better for the prognosis of the implant. Then two techniques are available for this this kind of CAD/CAM healing abutment. You can either take a conventional impression, as you see in the top of the slide, or you can just scan it directly in the patient mouth using intraoral scanner. After that, let me go back. If we can see in the bottom slide of the slide where we use the intraoral scanner, then the software will detect the location of the implant. You can see in the monitor here of the device, after scanning, already the implant itself, the proper size, the equivalent size, the equivalent type of implant already merged into the virtual cast. Then we can design our crown or prosthesis on top of it accordingly. And the other way, the conventional way of just taking the impression, we just want to make sure there is no air bubbles and it is perfect impression, no dimensional changes. So all this engraving into the abutment is well captured into the impression, so we can put it also perfectly. Then a robot here can drill the lab analog into the cast as the surgeon place the implant in the patient mouth. So this abutment will be read by this robot, and the robot will know exactly the angulation, the depth and the width of the implant and place it into the cast. I will show you some cases afterward using this technology. So here, for instance, the biometry eye, this is software that after they scan the cast and then locate the implant in the virtual cast itself, the following step is to fabricate and design. Now, there is, as I show you, it's the same process that we made for customizing the abutment using the UCLA abutment and waxing up the abutment to the certain form and shape and location of finish line. Here, we can do all this in using the software by designing a customized abutment virtually. And after that, if it get approved, we can send this picture to a milling machine, which is later on can mill it in different material, the material of choice, of your choice, whether it is titanium. This one, the yellow one, is a titanium, a tin-plated titanium, so it looks like a gold, a yellow gold. You can mill it in zirconia also. Another recent technique after this one is using an impression coping, but they call it an impression, a scan post or a scan body. So instead of taking a conventional impression, I will show you here. This is a slide shared to me by Dr. Sari Barzanji. Here there is, after the implant placement, we use the scan body here instead of a conventional impression coping. The scan body also, it's the same way of the CAD/CAM healing abutment. It has certain features also, as you see here, certain bevel, shape, and to allow the software to locate the implant position virtually and correctly, and not only the position, the size in the virtual cast. After scanning this, and this material is a scannable material, so you can directly scan this. That's why it's called scan body. You can scan it in the patient mouth using an intraoral camera. After you scan it, this is how it looks like in the software. It's followed by correct designing of the superstructure and followed by milling or the crown. In this case, also, not only you can do the virtual designing, you can actually produce a cast with the perfect location of the implant. Many times, especially in the full mouth rehabilitation cases, and you really need a physical cast to check the case. In any cases, you really need the cast, so to check the case and before you try it in the patient mouth, to verify the centric relation, to do all the steps, you really require the cast. Here, we can produce the cast, many ways to produce the cast with the digital technology, either with printing or any other method, and then with the exact, precise location of the special lab analog that can click here into this cast perfectly. After that, you can continue construct your final prosthesis and deliver it into the patient mouth. Here, I don't know why it's this slide. I'm showing that the CAD/CAM, it is two processes. The CAD, which is computer-aided design, okay, and this is the first part of it, is designing the prosthesis utilizing a software. We can see here after we scan the scan body into in the patient mouth, the implant is integrated now into the virtual cast. Then we can design the crown and the abutment virtually using many tools and features into the software. And then in the last picture here in the lower right corner, after you are happy with the crown, you can choose the material you want, the block of the material you like, and locate the virtual crown design into it, and then transfer to the second, here, the computer-aided design, and then transfer to the second step of this manufacturing, which is called the CAM part, which is the computer-aided manufacturing. Manufacturing means after you design the prosthesis and you checked this design and everything now is desirable, then you can transfer to the second part, which is using a machine to mill the crown. Like here, there is two main manufacturing way in the CAD/CAM technology. It's either milling, like here, or printing. You always hear these two names in the digital field. So milling, that means that we have already made block, a material, a block of a material that then we mill it using different burrs and using the machine. The printing is another technology where most of the time we have the material is in liquid. So this is a subtractive way. The milling is a subtractive way, while the printing is an additive way. So we don't waste material in the additive. So it comes into a liquid. Then like the composite, when we cure it with the light just pass following our design and cure, polymerize the material in the specific site they want to produce the final restoration. So now after we understand the conventional way and then the digital way, and I'm just keeping it simple and moving step by step just to understand how we conventionally do it. So anyone that don't know the basic, as I said before, he cannot use this tool, the digital tool, to design the final prosthesis. So that's why I took it conventionally to digitally, so we can understand how can we use this technology in our favor or advantage. So I will come now go quickly through many cases, simple cases. I just want to show it to you how I integrate this technology into the treatment of these cases. Case number one is using the CAD/CAM healing abutment. As I showed you earlier, this CAD/CAM healing abutment has certain features. I just took a conventional impression, make sure there is no voids or no dimensional changes into it. I poured the cast properly, a proper way, with the vacuum, mixing, use the ratio, powder to liquid ratio correctly, so there is no expansion, and I preserve the physical, mechanical properties of the gypsum product. After that, I send this cast to the company. As you see earlier, the robot drill the implant into the cast precisely. And also in the company, usually they design the abutment and send to you a two-dimensional image in different position to evaluate. Sometimes they send it three-dimensionally, so you can check the design, you can modify the design, you can ask for certain modification before the approval. After you approve it, they mill the abutment according to your choice of the material and send it back to you. You can try it into the patient mouth and continue the case conventionally or digitally as you wish. Here, I just continued conventionally by fabricating PFM fixed dental prostheses, and I tried the metal, I verified the centric relation, and then this is the final prosthesis. It's very simple. Everyone can do it. Now we can break the barrier and we can utilize the technology to do simple cases. Here, it's another case. Also, I use the same CAD/CAM healing abutment, but here in the anterior region. We can know, you see it's a long span edentulous area. We have 4 implants. The angulation of the implant following the bone, it's not really into our favor. I will show it to you why in the next slide. Here in this cases, we should design our final prosthesis or abutment regarding after we evaluate or at least do a provisional or waxing up to evaluate the phonetics, the aesthetics in these cases. So we guide the technology, we guide the technician. We are dentists who are treating and responsible for these cases. We should guide them the way how this prosthesis should be fabricated. So by making sure of all the required end result we want, so we send to them the wax up or the provisional restoration so they can follow it during the designing of the prosthesis. So here, this is the case, and then I took the impression. The implant lab analog has been placed by the robot. Here, I asked them to bring the cast to me back so I can do the wax up. I tried it into the patient mouth, and I asked them to scan this wax up. You can see now the wax up is scanned and over, they call it double scan. So they put it over the original virtual cast so they can design the implant as if I am using the putty index I showed you in the beginning when I did the customized abutment. And then if they send back the abutment to you, you can check it and then if everything is approved, they can mail it to the desired material. Here, I like to use the tin-plated titanium to resemble a gold because it is in the aesthetic area. And if you can see here, this is another picture, how many pictures they send it to you to evaluate the length, the location of the finish line, the dimension, and if everything approved, they can mail it and you can try it in the patient mouth. You can see clearly here that I did some certain modification into the abutment in the try-in stage. That's why I want to stress that CAD/CAM digital dentistry It is a helpful tool, but it's not a magic. They cannot do the job for you. As if we do mistakes in the conventional way, sometimes there is some mistake could happen using this technique. After that, I finished the case by doing this procedures, and this is the patient, how it looks like in the end. I will just move faster for the time. CAD-CAM abutment. Here, I will insist showing this case because I used a mix between conventional and the digital way to have the best aesthetic result. We can see the patient here came with a broken tooth that is diagnosed to be non-restorable tooth. We decided to do an extraction for the tooth and immediate placement of an implant. The immediate placement, one of the advantages of the immediate placement of the implant and immediate loading is immediate restoration. I mean that we can preserve the soft tissue. As you can see here, the lateral incisor is not in the perfect position. It's angulated, a little bit angulated. If you can see the contralateral side, the opposing lateral incisor, we have to mimic this way to be symmetrical in shape. The best way to preserve the soft tissue around this recently broken tooth, okay, so we don't have to do an extra procedure later on, and we preserve what we have from the tissue now to the final restoration. We can see the atraumatic extraction has been done and followed by immediate placement of the implant. Meanwhile, this is maybe it's a little bit sophisticated. I will try to make it simple. Here, the first picture to the left, that in the patient mouth, when the periodontist placed the implant, I just use an impression coping. I attach it to the implant, and because there is a blood and it's very difficult to take impression, so I just use the next two teeth, the neighboring teeth. I did a GC resin or Duralay that fits into the neighboring teeth and attach the impression coping. Then I already have a cast for the patient, which I made a hole into it that I can place the impression coping with the lab analog and add some stone back to it to attach this lab analog to the cast. Now I have transferred the implant position from the patient mouth to the cast. This is the first step. The second step, as you see here, I have the extracted tooth and the broken tooth. I have it. I preserve it with the first third of the root that form the soft tissue, that the gingiva has formed the soft tissue around it. So I preserve it. I took it, I place it into the cast using the clear shell here, as you can see in the picture, and I inject an impression material around the root. So now I have the exact soft tissue in the patient mouth transferred to the cast while the patient is doing the implant placement. I quickly do the screw retained provisional crown here. As you can see, it has the shape of it, the emergence of it. Following the emergence of the soft tissue, I polish it very well, and then insert it into the patient mouth. Immediately, as you can see here, you can see the gingival margin of the lateral and compared to the other lateral is the same. I preserve what I already have before. We preserve the papilla and everything, and I make sure there is no contact during occlusion. After osseointegration, this is immediately, we can see how the soft tissue heal around the provisional restoration. This is the best way to preserve the soft tissue around the implant is by doing a well-contoured and polished provisional restoration. This is after 8 weeks, and this is after 16 weeks. You can see the occlusal view. Even my provisional restoration look exactly similar to the other side. Here, the picture in the bottom of the slide showing the soft tissue around the implant. This is what we call it emergence profile. Okay, it has the papilla. It has the same emergence that we need. Here, what I told you that I just place the CAD/CAM healing abutment here quickly and inject the material around it, so the soft tissue around the implant is captured very well on the impression. They place the crown. Now you can see the abutment, the soft tissue virtually, and we can follow the margin that we created, the gingiva that we created during the fabrication of the abutment. I fabricated, if everything is okay, they mill the abutment, we do the try-in, and then the final cementation. We can see the final crowns here looks similar to the lateral side. This is the final, what it looks like. Case number 4 is how to utilize the CAD/CAM in edentulous patient by doing framework design. Here, a patient comes with edentulous mandible while she has some fixed prostheses on natural teeth in the maxilla. She placed, due to lack of bone only from the symphysis area, to place 4 implants, and we want to do a fixed complete denture, and in another term we call it hybrid prosthesis. Here, to do so, we have to do a final impression and then a trial denture here. So to decide the location of the final prosthesis, we have to do a trial denture, jaw relation, teeth trying. This is the trial denture on top of it. And then we have to do something called a verification jig to verify the position of the implant from the patient mouth and the cast exactly the same. There is no distortion in the cast. If everything is okay, then we can fill an electronic form or a form and send it to the company to fabricate a framework to support the acrylic prosthesis. I will go quickly through the form. In the beginning, we just do the data of the patient, the location, the dental clinic. Next, this is a checklist that where you have all the items I indicated already present. Then here, this is the many designs that you can select. I will not go through everyone, but there is the hybrid bar, the hybrid design. There is the header bar, the dolder bar, bar with extra attachments like locator, bars with clips. You can have a smooth surface, metal surface in the bottom, which we call it or wrap around, that you want acrylic that wrap around the bar itself. Then here in the second part, you specify the implant site and location, the number and the size of the implant. Here you can mention the extent of the bar. Where do you want this bar end, or you want to restore to which tooth? I will just show you one of the techniques, what we call it the anterior-posterior spread from the center of the most anterior implant. You do a horizontal line to the distal part of the last implant. Then you measure this area. You can extend and do cantilever design. This is the original hybrid prosthesis, 1.5, the time, the anterior-posterior spread. Here, this is the virtual designing of the framework. You can see clearly the teeth, the trial denture here scanned over the edentulous span area, and you can design the framework within this teeth, so it doesn't go more buccally or lingually than to support the acrylic prosthesis. In this specific case, we decided to do something called lateral screws. because if you can see in the lower corner, right corner, all the access hole or many of the, some of the access hole of the implant comes to the facial surface of the incisor teeth. So we decided to do a lateral screw rather than a vertical screws. Now, this is how it looks like, the framework. We tried it into the patient mouth with a test called a one screw test, that with one screw, the framework should be passively fit to all implant, and then we have to verify it with a radiograph. We did the superstructure now, and we process acrylic into it and using lateral screws. And this is how it looks like into the patient mouth. I'm sorry, I'm going a little bit fast because the time. Now this is an oral rehabilitation case using digital dentistry. This case started with Dr. Muhammad Fahmi. A patient came with broken teeth. They decided to extract all the maxillary teeth and designing for placing of this implant. In the lower, also here extracting all these teeth and placing 4 implants with cantilever design. This is after extraction, diagnostic waxing, drying of the waxing. Very important in the designing phase, so it's a prosthetically driven now implant placement. We transfer the wax up to the radiographic template that we can do CT scan that showed the exact location of the future teeth. And then this is a virtual designing of the implant according to the already tried wax teeth. This is a guided surgery where already the dentist, the periodontist or the surgeon can place the implant guided by this technology, so it minimizes the error during placement, also to precisely place the implant in the exact location that we want. After placing the implant, I continued this case. So I have to do a provisional restoration for the case. Here I took a conventional impression, did a provisional, use the temporary abutments, and then this is the temporary abutment into the patient mouth. I did a provisional restorations. Now it comes the digital way. And we can scan this digital provisional restoration and scan the implant position, and here is the scan of my provisional restoration on top of the scanned implant position. Now we can design our superstructure perfectly to according to the provisional. Here I use the framework, a screw retained framework that has abutment on top of it. It's 3 frameworks, separated framework in the maxilla, 1 framework in the mandible. It has a prepared teeth, so later on we can cement the crowns individually, or 3 teeth connected to each other. This way, if any complication happen to the crowns, to the porcelain, we know the lack of tactile sensation, especially the patient here is completely edentulous in the maxilla. We have low proprioception, sensation in the patient. The liability of prosthetic failure is high. Doing this design, we secure that the framework now is reduce the potential of complication into the framework, while the complication that happen due to lamination of the porcelain or fracture of the porcelain, then we can easily just replace the broken tooth or teeth, rather than replacing the whole prosthesis. If it was a 1 unit or porcelain fused to metal screw retain procedure. This is the framework after we review the design. They mill it, they send it. You have to try it in the patient mouth, do a 1 screw test, verify the centric relation. I do 1 step. It's not needed, but I did it, waxing up on top of the framework. I check the aesthetic and phonetics, and then I scanned the diagnostic wax, the waxing up on top of the framework. Now I can also control the design of the substructure of my crowns. You can see here the zirconia crowns coping are well designed for anatomically and following the diagnostic wax, which is I already evaluated into the patient mouth. The same thing into the lower teeth. We scan the wax and we do the diagnostic, the zirconia framework, designing virtually. Later on, you can mill the zirconia and apply the porcelain. Here, this is how it looks like. And you can do a bisque try in the patient mouth, just verify the centric relation again, verify the occlusion, do minor adjustment. And after that, you can apply the gingival part into the framework and finalize the case. This is just to show you here as if we replaced each tooth for the patient with an abutment and then followed by a cemented crowns. Here, the patient, after we finish, this is the final procedures. And this is the insertion of the case. Also, this is the frontal view of the case and the final smile. Okay, why CAD/CAM technology? So there is many advantages for the CAD/CAM technology. Is the precision of fit, truly passive fit, framework manufactured in 1 piece, no indexing, cutting, and soldering. Most of the time, if you are verified your cast, the fit is perfect, no need for cutting or laser welding, less expensive than casting into gold, available for most major implant brand, and here the most important part, duplicate anytime. So if any failure happen, you have already the software designing saved into your computer. You can, rather than repeating every procedure, you can just, with 1 click, manufacture another procedures. Okay, this is my question, and I will answer it by presenting 1 quick case. I am really sorry to pass the time. Is CAD/CAM technology a total substitute for conventional approach? You have to think. My answer is definitely no, because the conventional approach is the fundamental, is the basics as I show you. We can use the technology, maybe the whole workflow with this technology if possible, but most of the time the cases comes with certain difficulty. Every case is different than the other cases, depending on the proper diagnosis, the proper treatment planning of the case. This dictates how I would go to the cases. So what if you don't have a CAD/CAM technology? So you will not do the procedures? No. What if the patient doesn't have the possibility to place implant? Do we get stuck and just stop? No, we have, if we have the fundamental, then we can use the technology to support our treatment. I will show a case where I did not use CAD/CAM technology and I reached to the same result. Just here, a patient that has 1 missing lateral incisor. We can see the other lateral incisor here. Always I'm looking to the other side because the most important is to have symmetrical teeth. We have a recession on the lateral side. This is the smile. We can see the patient has high smile line, especially during the 4th smile. So now everything is crucial in this case because the patient is showing the gingiva. Here, first, the periodontist, we tried to do a gingival graft just to reduce this recession. And this is how it looks in 10 weeks. We have a good result. Then we did, and we planned to do an immediate loading, but we couldn't do that. So we placed the implant. Then we did after osseointegration, we did the uncovery. And here, this is what I'm telling you. We couldn't, sometimes we cannot do immediate loading depending to the case. After the uncovering, you can see this is the implant location. I did my first provisional restoration. You can see the amount of gingiva on the right side, different than into the left side around the implant. So if, let's say, I just took impression here using the digital way and do the crown, yes, it will fit perfectly, but it will not look nice. That's why I said the basics is very, very important. Here, I have to modify the soft tissue, okay, around the implant to mimic the contralateral side. I added to my provisional to contour the tissue and wait for several times. I do follow up to modify the tissue. It needs some patience until I reach, we can see this is the provisional, 3 weeks, 10 weeks, 16 weeks. Now we have achieved the exact location of the marginal gingiva in comparison to the lateral, the other lateral. Here we are very satisfied. I was very satisfied. You can see here how the emergence profile is created, okay, by the provisional restoration and changing the contour of the restoration. This is I will not go through here. I just captured the same soft tissue in the cast, and the implant was a narrow neck back then, narrow neck implant, and the patient, this is in the anterior region. I prefer to have a white looking abutment rather than a metallic one, just in case of further recession happen. I want to have a white abutment. Back then, narrow implant abutment. There was no zirconia abutment that can be fabricated due to the narrow connection that could lead to fracture in the abutment. So I use the conventional PFM alloy to cast my my abutment, and then I apply a porcelain to do a porcelain margin into the abutment, followed by a crown. Nowadays, this technique could be done using a tie-base restoration, a tie-base abutment, where later on we can do either cement or screw retained abutment using a substructure of zirconia or lithium disilicate. But this is, I'm telling you, the conventional way you can do it. This is how the abutment looks into the cast, the margin located subgingivally, and this is in the patient mouth, and this is the final crown. If I show you this picture before, you cannot say this is an implant. You will say this is the all natural sound teeth. You see, this is before and this is after. This is before, smiling, and this is after. You can see the high smile line. And now this is my last quote. I will end my talk with this quote. Digital implant dentistry is a tool that needs an operator. It's a tool that needs an operator that can manage it and give it the instruction. And this is, as I told you before, if you have the latest car and with the highest technology, you still need a driver. I really would like to thank you all, and I apologize for that I exceeded my time. I really hope that you like and understand my presentation. Again, I would like to thank the Saudi Prosthodontic Society for the invitation, and on behalf of myself, and I'm representing also King Abdulaziz University Dental School and University Dental Hospital. We would like to thank you all very much for your kind participation.
Thank you, Dr. Osama, for this amazing and informative lecture that we really enjoyed. And just to remind the audience that only the SPS members, the Saudi Prosthodontic Society members, will receive the certificates for these online seminars through email. And dear audience, like always, please answer today's question that was given by Dr. Osama, that's shown on your screen right now, on our Twitter account at Saudi Prostho. Now back to you, Dr. Osama. If you can please answer the questions from the audience.
Of course, thank you so much, Dr. Abdul Karim. Okay, so the first question said, amazing lecture. Thank you for your informative presentation. What is the difference between the external connection and internal connection? And is there a difference in technique between them when we take the impression digitally? First of all, the external and internal connection, there is two types of implant, external and internal connection. Do you see the hex, the connection in the implant itself, the platform? It's either inward, it's called internal connection, as most of the cases today I show you that the abutment has an external part that fit into the implant. This is internal connection. The external connection, no, the implant have the hex part is protruding from the implant. And then the superstructure has the negative part, okay? Originally, it was the implant, the first design was external hex. However, there was some disadvantages regarding this technique mechanically. Maybe it need another talk to know the exact difference between these two kinds. However, the most important part during taking the impression digitally is to use the equivalent impression post or scan body. You have the implant company should have an equivalent part that we can place it into the implant and then scan it. By this way, we can transfer the position to the virtual cast. Okay, why did they use robot with CAD/CAM abutment? Can we design it virtually without the robot? Yes, I told you two techniques. We can do it conventionally by taking conventional impression, okay, and then ask for a cast. Sometimes you need a cast with the location of the abutment, with the location of the implant. If you want, let's say, to do a provisional restoration, to verify the centric relation, to change some thing during the journey of the treatment, you really want a physical cast. That's why you need it. But on the other hand, you can use virtual, let's say if it's single crown, or you don't have to ask or pay for to do a CAD/CAM cast for you with any technique I already mentioned. Maybe you can just design, or if you have an in-clinic, a chair-side software and milling machine, you don't have to pour a cast. Then you can just scan it, design it into the computer, mill it, and just try it and finalize it into the patient mouth. Does loading time of the final procedures differ if we use conventional or digital implant procedure? Actually, no. There is no difference. It's only depend into the patient health, the implant torque, and in the beginning, the initial torque of the implant. If there is associated bone grafting during implant placement or not, all these factors, the occlusion of the patient, many factors determine when to load the impression. Yes, some people said an atraumatic procedure during the implant placement, like using the guided surgery, could facilitate or make the healing faster. So it could have an impact, okay, on the healing process, yes, but not using the digital way dictate how, when to load the implant. Okay. What material is used to restore soft tissue in cases number 5? Thank you for your information. I used the composite. Gradia, I think it's called. With composite, it has many shades and it's easily repairable, and it has a good bonding strength to titanium. Thank you, Ahmed. What is the difference between? Okay, I already answered these questions. I don't know if there is more question.
I think that's it because of the time, Dr. Osama, and thank you for answering all these questions from our audience. And by the end of this webinar, we would like to thank you all for your attendance and your time. We would like to ask you kindly to stay home and stay safe. May Allah be with all of us through these times. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا وزدنا علما يا رب العالمين. السلام عليكم ورحمة الله وبركاته.
I just want to say something for the audience, because the time and I doesn't have the chance to receive all the questions. I answered any question that I received now. If you have any questions, I already post my all social media account into the, it was noticed into the slide. You can send the personal message to me and I will be happy to answer it. Thank you very much.
Thank you. Thank you so much, Dr. Osama.
Okay.
And thank you for your attendance.
Okay, bye.